Hi, my name is Dr. Robert Kaufmann, and we're about to go beyond the terminus. In this session, we're going to find out how to locate MB2. There's no question that one of the most challenging teeth in endodontics is the maxillary molar. This tooth frequently requires endodontic retreatment because of a missed MB2. The reasons that clinicians miss MB2 are varied. They include lack of understanding of the anatomy of the maxillary molar, inadequate or absent three-dimensional radiographic imaging, inadequate magnification, and insufficient illumination of the axis. In order for us to understand how to locate MB2, we have to first examine the anatomical configuration of the maxillary molar tooth. Anatomic studies have shown that MB2 is present in 90% or more of the maxillary first molars and 50% or more of the maxillary second molars. The exact numbers will depend upon which study that you choose, but we can agree that if you don't find MB2 in maxillary first molars, at half the time in maxillary second molars, you should be concerned. In many cases, MB2 will join to MB1 at some location along the canal space of MB1. In the case of a vital tooth, missing a small portion of the canal space in MB2 may not be that important because you've already sealed the entire length of MB1. In that case, it's likely that the patient may remain asymptomatic and you may have dodged a bullet. In other cases where MB2 is a completely separate canal and where the pulp has become necrotic with associated periapical radiolucent findings and symptoms, you may not be so lucky. Endodontists frequently have to retreat cases like this and very often find untreated MB2 canals. So, how do we find MB2? It's very important to have a good magnification source and a very good light source to be able to see adequately. 2 or 3 times loupes and a headlamp is often not enough, I'm sorry to say. Locating MB2 is dependent upon seeing subtle shade differences in dentin and recognizing anatomy of the pulpal floor. Clinicians should be careful not to indiscriminately take round burrs and destroy important landmarks on the pulpal floor in a search and destroy mission and an attempt to locate the orifice. These grooves along the pulpal floor and the changes in dentin coloration are the roadmap that enables you to see where the canal orifices may be located. Haphazardly removing dentin in the hopes that you're going to find an orifice is essentially turning off your root canal GPS. It then becomes easy to get lost and perforate the access. Prior to access, we need to closely examine not only the PA, but the bite wing image to give us an idea of how far the chamber may be from the occlusal aspect of the tooth. Younger natural teeth will have large chambers that are easily penetratable. Older, heavily restored teeth will have chambers with large pulp stones or heavy secondary dentin deposition. This makes chambers hard to locate. These findings have to be anticipated before we attempt our access. In certain teeth, we suspect that restorative materials or pulp caps may have caused pulpal symptoms. The extent and proximity of these materials to the pulp can sometimes give us a clue as to where the chamber or orifice may be if we suspect a previous exposure has occurred. Pulp protective agents such as Dical, which may have washed out due to leakage, can also help guide us to an initial entrance into the chamber. Once the chamber has been accessed, we always should attempt to find the easiest canal first, which is generally the palatal canal because it's often the largest. Depending upon the case and radiographic appearance, one could move to either the distal buccal or mesial buccal area, tracing the groove along the pulpal floor. In the case of a vital tooth, this is fairly easy because there may be pulpal remnants or bleeding in the grooves. In the case of a necrotic tooth, there may be some discolored pulp tissue or a small thin groove or dark line in the dentin. It's important not to remove these grooves because they are our roadmap in locating the other orifices and the other canals. Another significant aid in locating canal orifices is color. The change in dentin color between the pulpal floor and axial walls, both mesial-distal and buccolingually, is usually quite dramatic, and it can be emphasized with a transillumination device that can be sometimes very helpful. It's essential that the clinician has enough magnification and illumination to be able to see this difference. Axial dentin is usually much whiter in its natural color when not stained by caries or restorative materials such as amalgam. Because the dentin of the pulpal floor is somewhat translucent and somewhat thinner, it generally has a darker appearance. The orifices of the canals are found at the intersection of these two colors. Exceptions can occur in cases with heavy calcification. Secondary dentin deposition in the chamber tends to be more clear in color and has been described by some clinicians with the appearance of glacial ice. They are best removed with ultrasonics or explorers rather than a burr, especially one or more of the orifices has already been opened or instrumented. Using a burr can sometimes loosen the calcification and force it into an adjacent canal entrance or down another canal, making it hard to instrument the tooth. It can be very frustrating to have cleaned and shaped a canal only to have a perfectly round-sized pulp stone from an adjacent area fall into the prepared canal and cause severe blockage. That's why taking time to work on the access cavity is so important. As my friend Dr. Terry Pankak says, extra time invested in refining and perfecting the access cavity is well spent because of the dividends of better vision, directness of access, ease of instrument placement, and prevention of blockages by loose dentin. Once MB1 is located, higher levels of magnification are used to trace the groove running from MB1, usually in a palatal and mesial direction. MB2 is usually located under a dentin lip that projects from the mesial side of the pulp chamber. This lip has to be removed in order for us to expose the orifice and allow the file to be inserted. If you don't remove this lip, this structure will result in the instrument having to be inserted at a very acute angle from the distal aspect of the tooth. This predisposes the instruments to fracture because they first have to negotiate this first sharp curve in the most occlusal portion, then another curve, usually distal, in the mesial buccal root. It's imperative that rotary instruments are not placed into the orifice at this point, because attempting to power through this initial curve can result in fracture of the instrument either in the orifice or deeper down. Small burrs such as Mueller burrs, Muntz burrs, or ultrasonics are used to remove this mesial lip. By doing this, you'll note that the initial negotiating instruments such as a 6 or 8 file will begin to stand more vertically, rather than need to be finessed and guided from the distal aspect of the axis into the orifice. Special note should also be made of how close the MB2 orifice is to MB1, and whether the instrument glide path seems to be pointing the file in the direction of MB1. Both are indications that there is a high possibility that MB1 and MB2 canals are joined. If MB1 can successfully be negotiated to the apex, I prefer to clean this canal entirely first and then move on to MB2 last. The advantage of doing this is that we can occasionally shorten MB2 where it joins to MB1. Shorter canals are usually easier to treat and negotiate. Check out my other video on how to determine whether MB1 and MB2 are joined and how to figure out where they're joined. It's imperative that we know where these canals join so we do not tear the common foramen by placing instruments to the terminus from 2 different angles. Remember, we can't regenerate dentin. We can only replace it with restorative materials that are always inferior to natural tooth structure. If you don't feel confident with canal location, or if you reach the point where you believe you may be jeopardizing the restorability of the tooth, stop. Consider referral to an endodontist before the tooth is too badly involved. Judicious case selection is part of good dental practice, and proper case management is important for the ultimate result for your patient. Thanks for watching this video. Remember, when we do the right thing, we definitely both get better, both patients and clinicians. Join me on our next trip when we go beyond the terminus.